Hello again, it's Dr. Jack with the extended vignette questions, and I have a couple of cases here to share with you, these extended vignettes that are in your exam. And we start off with the case of Casey. So let's go through this. Casey is a 13-year-old girl brought into the emergency department by her father and paternal grandmother, who report she, quote, once again threatened to kill us while waving a knife. Casey's been in 5 different schools due to disruptive and violent behaviors. Grandmother reports that starting in 1st grade, Casey has bullied peers and started fights. She doesn't only shove but punches hard. One time she threw a rock at a child's face. Another time she threatened to kill a teacher who reprimanded her. Once she found a nest of rabbits under a bush and poured gasoline and watched them burn, laughing how they were squirming. She has also started fires on neighbors' porches. Casey was removed from mother's care while an infant. Father has a drug abuse problem and has been incarcerated several times for drug dealing and theft. Grandmother is wheelchair bound and, quote, can barely take care of myself, let alone take care of Casey. Grandmother also reports that Casey has been engaging in sexually inappropriate behaviors starting in 2nd grade. Casey has been in the juvenile justice system, last time when she smashed her cousin's head against the floor, causing a concussion. During the interview, father sits quietly. He seconds grandmother's descriptions but has little to add, saying he's been, quote, mostly gone. Medical records disclose Casey has been hospitalized on child psychiatry multiple times since the age of 7 for violent behaviors. Various medications have been started, but adherence to treatment after discharge has been nil. Neuropsychological testing from last year discloses verbal IQ of 115 and performance IQ of 87. Projective tests disclose themes of violence, sexual activity, and belief in the universal malign intent of others. So let's go through our series of, I think I have 10 questions here. Which psychiatric disorders does Casey most likely meet the criteria for? And choose 2. Antisocial personality disorder, attention deficit hyperactivity disorder, conduct disorder, disruptive mood dysregulation disorder, and impulse control disorder. And conduct disorder and impulse control disorder, intermittent explosive disorder, I should say. So she's likely to go on and develop antisocial personality disorder, but she's only 13, and so antisocial personality disorder, you have to be at least 18. Now she might have ADHD, but there's really no information that talks about that. Right? And then disruptive mood dysregulation disorder has 2 main features, right? 2 main kind of symptom categories. One is these frequent temper tantrums, and the second is this ongoing irritability. So one could make a case that she has ongoing kind of hostility/irritability, but there's really nothing in particular about temper tantrums. So I think this is one of those cases where when you're faced with a question such as this, you really have to think about what do you have positive evidence for. Not something that could be there, because a lot of different things could be there, but what do you have at least a little bit of evidence that you can kind of hang your hat on and say, well, this really the way it's described would be a symptom of this disorder, so it kind of, there's positive evidence to get it onto my differential list. Doesn't mean it's right, it just means that there's some evidence for it to pursue further. Which areas of inquiry will be most urgent to address during this evaluation? Choose 3. Patient's current safety, history of child abuse, safety of others, child neglect, or history of head injury. Choose 3. What are the 3 most important ones? Well, the safety ones, right? Her current safety, safety of others from her, continuing violent behaviors, setting fires. I mean, a whole household of people can burn to death. And then also child neglect. And again, we have positive evidence for that. Grandmother says, I can barely take care of myself, let alone this child. And yes, there's a father there, but he says he's mostly gone. So this is definitely an acute situation. Which of the following statements is most accurate about Casey's recent IQ test results? Combined IQ is in the normal range. Her IQ is consistent with borderline intellectual functioning. The patient shows exceptional verbal abilities. Significant differential exists between verbal and performance scores. The patient's behavior is consistent with her IQ scores. So the thing that really jumps out, and this is here particularly, I added this information to this vignette and this question, is because there's more than a 10-point spread between her verbal and performance IQ scores. And that's significant and meaningful. And that should kind of raise a red flag. So the patient's differential between verbal and performance IQ scores is most likely to suggest which of the following. Choose 1. It's a normal difference between various cognitive functions. There's a possible history of traumatic brain injury. The findings are consistent with post-traumatic stress disorder. They're indicative of vitamin B12 deficiency. Or, last option is strength in one area can compensate for weakness in the other. Which will you choose? Well, we have to think about there's something wrong with her brain. And certainly, given her history, traumatic brain injury is a real possibility. We don't know that, but there's something here that accounts for that discrepancy. Now, it doesn't mean that there's been any brain injury or any other, identifiable brain disorder. She might have, very specific learning disorders. But then this is something that certainly needs to be further evaluated. Now, what about the vitamin B12 deficiency? Well, that's way too specific. We don't really know what the cause is yet, but there's something there's something going on. And traumatic brain injury seems to be much more likely, and kind of, it's a broader category. On further evaluation, Casey is given conduct disorder as her primary diagnosis. Which conduct disorder specifiers is she most likely to meet? Choose 2. Childhood onset type, post-traumatic onset type, with intermittent explosive behavior, with limited prosocial emotions, or with pyromania. So you're going to choose 2. Childhood onset type and with limited prosocial emotions. Those other ones I just made up. They're not in the DSM-5. But it's very important to look this up, and it's included in my lecture on conduct disorder and oppositional defiant disorder. And these are both very important specifiers because they are both associated with poor outcome. Now, Casey is 13, but she's been hospitalized for violent behavior since the age of 7. So definitely she's been having these symptoms before the age of 10. And then with limited prosocial emotions, among others, that includes like the lack of guilt, the lack of remorse, and just like kind of a lack of positive emotions towards others. And that is also associated with poor outcomes, and in particular, the then conversion to antisocial personality disorder. On laboratory testing, which of the following tests would be most important to order? Choose 3. The FMR1 gene test, a pregnancy test, the RAI1 gene test, STD screening, or urine toxicology. Which are you going to choose? Which three? Or if you prefer, which two will you eliminate as being less important? And yes, so we don't know if she's sexually active now, what's going on. She definitely has sexual preoccupation. The grandmother, without elaboration at this point, says that she's been acting sexually inappropriately. So we need to certainly consider, or not just consider, but I would say get pregnancy testing and STD screening. And then in addition, given her history, the chance of drug use is quite high. We know that her father, who has drug abuse problems, is now living in the home. He may actually be, in some way contributing to her, and even they might be using drugs together, which is not unheard of. So those are the three most, urgent things to look at, highest yield. Now, which additional diagnoses is the patient most likely to have? Choose three: acute stress disorder, attention deficit hyperactivity disorder, post-traumatic stress disorder, social communication disorder, specific learning disorder. You're going to choose three or eliminate two, whichever you prefer. Some questions, they lend themselves to one strategy, the elimination strategy, better than the addition strategy. So whatever works best for you. Not that I have really highly specific information about ADHD, but there's a high comorbidity with the disorder, with conduct disorder and her other behavior. Certainly, her behavior has been sexualized since early age. It's highly likely that she has been victimized, child physical and particularly sexual abuse. So PTSD needs to be evaluated. And then again, given her IQ scores, the discrepancy, a specific learning disorder certainly needs to be high on our list. Acute stress disorder, well, it sounds like there's been, this situation has really been chronic. Certainly a lot of crisis exacerbations, but this has been going on like for half her life right now. So it's unlikely that it would be acute stress disorder, much more likely that it's post-traumatic stress disorder if present. After conferring with colleagues, you ask for a neurologic consult and plan to order a neuroimaging test. Which of the following studies of the brain is most likely to yield relevant information? CT with contrast, MRI diffusion tensor imaging, MRI flare sequence, PET glucose metabolic study, or SPECT perfusion study. Well, our kind of go-to one here will be just a brain MRI, which will give us a T1 weighted sequence, and then the flare sequence, which is very good for identifying pathology, brain pathology. We call that in the flare sequence, the CSF signal is suppressed, so it's easy to tell if there's been kind of brain injury or other kind of brain pathology going on. And again, usually, the baseline, the foundation of an MRI, a structural scan is a T1 weighted image, which is like our anatomical image. The flare sequence is very good for brain pathology. Now, what about diffusion tensor imaging? That's certainly good for identifying shear injuries, white matter tract injury from a blunt head trauma, motor vehicle accidents, from fighting, from sports injuries, from falling down and hitting one's head. But that's much more specific. And that might end up being ordered and relevant, but it's not going to be our first study that we get. Now, the MRI is certainly going to be much more relevant than getting a CT scan, even with contrast. Usually we're going to get a CT with contrast if we're thinking about neoplasms or particular types of brain infections. And again, CT also has the problem of, exposure to ionizing radiation. That MRI does not have that risk. And then looking at blood perfusion or glucose metabolism is really not relevant at this point. You decide to admit Casey to the inpatient psychiatry unit. You need to have the guardian sign the patient into the unit after obtaining informed consent from the guardian. So who is the guardian in this case? Is it the mother, the father, grandmother, the state, or unknown? Well, clearly it's unknown. We don't know. I didn't say, we don't know. The whole point here is to kind of highlight for you, not that I don't think you found this hard, but I think the kind of learning point here is to always be aware that, you may not know who the guardian is, and you do need to identify them, and then have some way of having it substantiated that they are the guardian, hopefully looking at paperwork that says so. Question 10. You admit the patient to the unit where many staff already know her, right? You quickly learn that staff have strong opinions about this patient. Some staff find her a, quote, cold-blooded psychopath, and others say she's, quote, a victim of abuse, a chaotic upbringing, and a failed child welfare system. Which of the following do you decide to do the first day of hospitalization? Choose one. Nothing. You need to observe how these staff views, play out. Or you call a staff meeting to discuss the patient's case. Or you place a consult for a medical ethicist to provide guidance. Or you order projective testing to ascertain source of the patient's behaviors. Well, clearly the most relevant one here is call a staff meeting. 11th and last question. The staff are displaying which of the following behavioral phenomena? Choose one. Introjection, parallel process, projective identification, staff splitting, or toxic workplace. Well, they may actually be, this may be kind of example of more than one thing going on here. But the most direct and relevant phenomenon is staff splitting. That then needs to be addressed in the staff meeting, because this is going to end badly. It can lead to staff recriminations against each other. It could lead to counterproductive behaviors of the staff towards the patient that may actually, in some extreme cases, be kind of like medical malpractice, because people are basically responding to strong emotions and doing things that are very counter-therapeutic and sometimes even, frankly, harmful to the patient. And of course, it really decreases staff morale. There's only one thing that I will add about staff splitting. It's really not helpful to think about it as that this is the patient's fault. Okay, the patient is the way the patient is. So the patient certainly is the trigger, the antecedent for these strong emotions to play out, these strongly diverging opinions. But this is really like a team issue. It's like a human group issue. And it's really not helpful or useful in terms of resolving the issue by kind of, in a way, blaming the patient. It's easy to blame the patient. I'm sure her behavior is very disruptive on the unit, and people may feel burnt out, be angry, be afraid, all kinds of things. So I'm not saying that the patient doesn't contribute highly to the situation. I'm saying it's more helpful to see this as a group issue, a group that is facing this type of environment that the patient brings on. But it's not like, oh, it's the patient's kind of fault, or it's due to the patient, and then once the patient leaves, it's all okay. Yes, these things may kind of certainly quiet down, but I think it's more helpful to think about it as a group. The group is the team. They're working together with easy patients, hard patients, and this could be a very important opportunity for them to strengthen their working relationships with each other and their therapeutic interactions with the patient, kind of setting control and yet not acting out in some counter-therapeutic or harmful way.